So this is what I've made for case 1, scenario 1. This is for learning outcome 3, which my group made, which was physically evaluate how the relationship between the shock response following injury and Jake's interpretation of pain works. When Jake hits the ground, a noxious stimulus is applied to his knee. This is the initiating event that triggers the biological processes that follow before any conscious experience of pain has occurred. At this stage, what's happening is nociception, which is the physiological detection of a potentially harmful stimulus. This is distinct from pain itself, which is the conscious, subjective experience that occurs later after central processing in the brain. Mechanical energy from the fall is converted into electrical signals through transduction. In Jake's case, mechanical deformation of tissue is the dominant driver, although superficial friction with the ground could also contribute thermal input if a friction burn is present. The first signals are transmitted by alpha-delta fibers, producing the initial sharp, well-defined shock sensation that follows the injury. These fibers are specialized for fast signaling of high-threshold noxious stimuli. Alpha-delta fibers do not normally transmit input from low-threshold mechanoreceptors such as Meissner's corpuscles, Pacinian corpuscles, Ruffini endings, or Merkel discs. Instead, they have free nerve endings in the epidermis that detect noxious mechanical change and high-threshold temperature stimuli. Because alpha-delta fibers are relatively myelinated, they conduct signals rapidly to the spinal cord and can engage reflexive motor neurons. This allows Jake to perform immediate protective movements such as shifting weight or stopping skating without requiring cortical involvement. This initial alpha-delta input provides the brain with an early quantitative report about injury severity. At this point, the information is largely sensory and descriptive, rather than emotional or interpretive. Following the alpha-delta signal, C fibers transmit slower, dull, aching pain. These fibers are unmyelinated and they conduct signals more slowly, contributing to the ongoing discomfort after the initial shock. C fibers relay information about how intense the pain feels, how long it lasts, and whether it's continuous. They convey poorly localized pain compared with alpha-delta fibers and are more involved in answering questions like, how bad is this, rather than where exactly is it? These nociceptive signals ascend from the spinal cord through the thalamus and onward to the cortex. At this stage, the information is being routed for conscious processing and interpretation. In a mature system, the brain can dampen ascending nociceptive input via the descending pain modulatory system. This system applies inhibitory control at the spinal level to reduce signal intensity. According to work by Fitzgerald, the rostral-ventral medulla exerts more excitatory influence early in life, with inhibitory control developing gradually through adolescence. At 17, Jake is likely still at an early stage of this transition, with reduced descending inhibition. Because the inhibitory brakes are not fully developed, nociceptive signals may be less effectively dampened. As a result, the pain signal reaching the brain is effectively amplified during the immediate post-injury period. Once in the brain, pain is processed by two systems. The lateral system, involving the thalamus and somatosensory cortices, determines where the injury is and how intense it is. The medial system, involving the anterior cingulate cortex and insula, processes how unpleasant the pain feels. Jake's final interpretation of pain is shaped by cortical processing of C fibre input combined with contextual cues such as seeing blood on his knee or noticing an abnormal position of his ankle. At this point, biological signals and situational awareness combine to produce the subjective experience of pain.